안녕하세요. K치과
Greetings.
강충규입니다.
I'm Dr. Kang Chung-gyu of K Dental Clinic. When you draw, the most important thing is the sketch. If there's no solid foundation, you will not be able to complete a great artwork. In the same sense, treatment plan reflecting patient's oral status leads to high satisfaction rates. I'm going to look at clinical cases and come up with treatment plan accordingly. Before we place implant, in the treatment planning process, let's look at the factors that we need to count in. Length and diameter of implant, appropriate placement, position, and angle. And if you're placing multiple implants, how many implants are you going to place? Are you going to do one stage or two-stage surgery? Are you going to do loading? In the interior area, how are you going to do temporary restoration? As mentioned, the most important, which has direct impact on implant prognosis, is appropriate placement, position, and angle. Let's look at the first case. 66 years old, female patient. She complained of discomfort in lower right. As you can see on the X-ray, number 40s, in number 3 unit bridge, on number 46, there was irreversible pulpitis due to decementation. Let's look at the treatment plan. Number 44, recrown was decided. I was not able to do bridge, so in this case, I would restore it with implant. For number 45, I decided to place an implant. In number 46, root canal treatment was planned, and a crown was also planned. If you take a look, in number 44, crown was done again. In number 46, as I was doing root canal, in the defect, if you look at the area for implant placement, there are several problems. First, there's lack of attached gingiva, and the remaining attached gingiva, in order to move it lingually and buccally, I did horizontal incision lingually, and in placement area, there was a lot of buccal bone resorption, so GBR was necessary. Another problem was mesiodistal length was quite significant, so although it was a premolar, diameter of 4.5 or more was needed. If you look at the CT, to mandibular canal, there was sufficient bone height, so I thought it would be no problem to place 4.5 by 10 millimeter. There was significant space mesiodistally. I decided to place 4.5 by 10 millimeter implant, and in the buccal side, there was insufficient bone. So slightly lingual implant was placed and full thickness flap was opened. Preliminary drilling was done and I placed guide pin and checked occlusion. Checked whether the teeth headed towards the functional cusp of the opposing arch, and also checked whether it came center of mesiodistally. And I took an X-ray and I confirmed that it was well positioned. Finally, after drilling, this is the image and mount has been connected. and occlusion was checked. Once again, the position was towards the functional cusp of opposing arch, and the placement depth was 8 millimeter. Because it's not in contact, it means that there was over 8 millimeter of space, and sufficient space was secured to give appropriate emergence profile. With mount on, we checked occlusion, and it is necessary to check the position and the placement depths as well as the direction. Finally, fixture drill was used and placement depth was adjusted, and as you can see, the fixture was not exposed buccally, but there was very little bone left. For implant stability, GBR was conducted. Healing abutment was connected immediately. Non-submerged GBR. In other words, transmucosal GBR was conducted and prosthesis was completed. If you look at the prosthesis, more so than number 4 mesiodistally, the length is much more longer. 4.5 millimeter or something thicker should be chosen. If you look at the X-ray, I put in the guide pin and check the direction, and after that, drilling was done. Thickness 4.5 and length 10 millimeter. The fixture was placed, as you can see on the CT, on the buccal. GBR was done. After 2 months, prosthesis was completed and CT was taken. You can see that area where GBR was done, it looks stable. This is a second case. 49 years old male patient and number 37 implant was to be placed. Extraction was done 5 months earlier. If you look at the X-ray, bone height up to mandibular canal is approximately 9.6 millimeter. If you consider safety margin, you should place 8.5 millimeter implant because there was insufficient bone height. Placement direction was very important. If it changes, even if you use the same length, it can go into mandibular canals, so we need to place the implant in the desired direction. You need to put the pin on and check in the middle. As you can see, I used the number 5 blade for incision, and for anterior, use blade number 5 to do cutting in the distal area. After incision, you retract the flap and you drill following the sequence. You use marking drill and mark 3 millimeter and you check the length. Mesiodistally and buccolingually, check the position, do preliminary drilling. Use guide pin to check the placement, position, and direction. Check the occlusion and check whether it heads towards the functional cusp of other arch. And mesiodistally, check the position and take X-ray for this. It is slightly tilted to the mesially. The path is adjusted slightly towards the distal. The placement position is not that bad, so path was just adjusted and drilling was done. Drilling was done in sequence, and at the final stage, guide pin was put in for checking, and drilling was done, and then implant was placed. Mount is connected, and you check the placement position and depths. The torque value is 15 newtons. After you place the implant, it's slightly tilted towards distal, so fixture was removed and you slightly tilted mesially. I didn't do additional drilling, but just adjusted the direction of implant. After changing the direction, the torque decreased slightly and it was 10 Newton centimeters. The direction was towards the functional cusp of the opposing arch, and the space was over 8 millimeters, so there was no issue in doing prosthesis. As direction was changed once, the initial stability was weak, so I chose a two-stage surgery. When torque value is not strong, the fixture can come out when you remove mount, so you have to use open wrench to hold the mount and then remove it. Mount has been removed, and using fixture drive, placement depth was adjusted, and in the area where the top of the fixture is exposed, cover screw have been attached. Autogenous graft from the drilling was used. Incision and suture. Modified restoration was done, X-ray was taken, and final checking was done. At first surgery, 5 by 8.5 millimeter fixture was placed. Three months later, second surgery was done, incision was done. In the area, cover screw area, you can see that bone has grown over, and in those cases, in order to find the cover screw, I use curette and remove bone here, and if you find it, cover screw is removed. It is removed and changed to healing abutment, and this is after healing was done. Healing abutment, you need to consider the size of final abutment. So 5 by 7 millimeter healing abutment was chosen. After 1 month, I took impression and prosthesis was delivered. You can see that implant was placed in the desired position and direction, so implant hole position is at the center. Let's look at the third case. 51 years old male patient, number 17 was missing and implant was to be placed. Let's look at the problem list. In most upper posterior area, if it has been a long time after extraction, there's a high possibility of there being soft bone. So in those cases, in order to get initial stability, you need to do under drilling by 1 size or 2 sizes. And in the case of soft bone, you need to have good direction and maintain that direction. If you continue to change that direction, you lose the chance to get initial stability. So you need to have the correct direction from the beginning. Look at the X-ray buccolingually. There's sufficient thickness, but bone height, as you can see, was 8.5 millimeter. In general, we would need to place 8.5 millimeter fixture. So using osteotome, I planned a socket lift to lift the top part, and because there was sufficient buccolingual thickness, 5 by 8.5 millimeter implant was planned. As you can see, I checked occlusion. Before incision, I checked whether it was normal occlusion or crossbite. I used blade number 15 for incision, and for distal area of the front teeth, I used knife number 5. I used periosteal elevator to retract the flap, and I checked the position for implant, and using marking drill, I first marked 3 millimeter and checked whether that position was appropriate buccolingually and mesiodistally. And after that, preliminary drilling was done, guide pin was put in, and I also evaluated placement, direction, and depth. I took X-ray. I evaluated whether the position was appropriate. After that, I proceeded with implant drilling. The important thing is you need to check bone density. As you drill, the resistance tells you whether it is soft bone, normal bone, or hard bone. You need to evaluate it. It was a very soft bone, so final drill, I took it down by 2 sizes. I under drilled by 2 sizes. At final stage, I used a osteotome similar to that size of the final drill, and socket lift was done, and it was on drilling mode. And if you place it, fixture goes in by 1200 RPM. So before you put the mount on, change to placement mode. After you connect the fixture and before you step on the pedal, check once again whether it's a placement mode and drilling mode, and it must be on placement mode to place the implant. With mount on, I placed it. I checked the occlusion and checked the placement direction and depth. The mount, it's kind of tight. It was not 8mm. It was slightly lacking. The final torque was approximately 12 Newton centimeter, and depth control was done. I did additional depth control, and finally I removed the mount. I used open wrench because initial stability was insufficient, and I held it and then removed the mount. X-ray was taken. I checked. It should go more distal. So using fixture driver, I did more depth control. I pushed it a little bit more. Finally, 5 by 8.5mm was placed. If possible, all rough surfaces should go inferior to the bone, and placement depths need to be adjusted. Initial stability. As depth was adjusted, initial stability was gained slightly. Healing abutment was connected, and it was one-stage surgery. Luckily, there was sufficient attached gingiva. Palachi flap was formed, and there was suture on the mesial side. After 3 months, prosthesis was delivered, implant was placed in the direction that we wanted, and socket lift was used. Osteotome was used for socket lift, and it is relatively stable. The fourth case, 71 years old female patient in number 24. Immediate implant placement after extraction was planned. If you look at the problem list, all implant placement after extraction is the same. Fixture size is smaller, so there's a bone defect, and because there could be a gap, GBR is required. In order to get adequate initial stability, you need to underdrill by a size. As you can see, the length was sufficient. Bone height was 4mm. 4 by 10mm implant was planned. As you can see, guide pin was used to check the placement position. It was adjusted, and I placed the fixture with the mount on. I removed the mount, and you can see the gap. I used autograft and allograft to do GBR. Immediately, appropriate initial stability was achieved, healing abutment was connected, and suture was done. This is before taking impression. After 2 months, prosthesis was completed. Take a look at the X-ray. This is an image before extraction. Guide pin was placed, and it was slightly towards the mesial, so direction was adjusted. Bodily adjustment was done towards the distal. The 4 by 10 millimeter implant was placed as was planned initially, and healing abutment was connected. Finally, prosthesis was completed. This is the image. Implant was placed to the depths that we wanted and the position that we wanted. Prosthesis was well made. If you look at the CT, buccolingually, bone is very sufficient, and you can see that it is in adequate position. This is the last fifth case. 62 years old male patient, number 35 and 36. Implant placement plan was made. As you can see on the X-ray, there is something unusual. Mandibular canal to mental foramen. The mental nerve is very long and clear. From number 35, the mental nerve can be observed where the implant is going to be placed, so you need to avoid it and choose the right direction. Problem list. In number 35, the mental nerve and mandibular foramen needs to be avoided, and the implant needs to be placed, as well as the depths and the direction. Needs to be evaluated. Attached to gingiva is lacking because it has been missing for a long time. Horizontal incision, slightly lingual, needs to be made. Because buccal bone has been rather resorbed, GBR process for restoration is necessary. If you take a CT, as you can see in number 45, slightly lingually, it needs to be placed in order to avoid mental foramen and mental nerve. If you place slightly lingual, it is 10 millimeters, so 8.5 millimeter fixture is to be placed, and the thickness is 4 millimeter. In number 6, the structure had no problems and the length was sufficient. 4.5 by 10 millimeter fixture was to be placed. As I placed the implant, I used the guide pin and CT was taken, but it's rarely done. But because there was mental nerve and mental foramen in number 35, and this needs to be avoided, I used guide pin and took CT to check whether the implant is being placed in the direction that we want and whether it is avoiding mental foramen and mental nerve. In the middle, I took CT. Accordingly, implant was placed in the thin buccal area. Transmucosal GBR was done, and healing abutment was connected. After I took a CT, I checked whether the implant went in the desired direction and avoided mental nerve and mental foramen and was placed in the ideal position. Clinical image with mount on. With the mount on, I checked the position once again, and finally, fixture driver was used to adjust the placement depths. As you can see on the buccal side, bone is very thin, but the fixture was not exposed, but for implant stability, GBR was done. Healing abutment was connected, and transmucosal GBR is done, and that's the way I favor it. In this state, I did GBR and connected healing abutment and did suture. By looking at multiple clinical cases, we planned the treatment plan ahead. There are multiple factors to consider, but key things to consider: the length and diameter of the fixture implant to be used, appropriate placement position and angle needs to be considered, anatomical structure needs to be avoided, and implant needs to be placed in that position, and stable prosthesis needs to be provided. Position and angle is more important than anything else. So even if one pillar falls, the entire building might collapse. If there is imbalance in the nutrition that we take in, the whole body balance crumbles. And that is the same for implant treatment as well. There are many things to consider and many things to experience. I hope you've learned a lot through the experience. I hope you continue to advance to achieve the best outcome. Thank you once again for watching.